and we might get started. So welcome everyone. There's a couple of things to kind of update for this area of the world on. The Nystagmus subcommittee has formed and had a couple of meetings. So I think the first update is that we will have a chair and a deputy chair. So Helena Lee and Rebecca McLean will be heading up the committee. So they're both based out of the UK. And the decision has been made that it will be a guideline rather than a standard as the first one that we put out, sort of in line with the ISEV type process. And the reasoning and the thoughts behind that was around a lot of the comments around guideline versus standard and what that means for some of the medico-legal aspects of things. And the willingness to kind of look at it and adjust it later as needed. So when something kind of becomes a bit more ironclad, to put it out as a standard, but putting that first one out as a guideline. ISEV has just put out a how to write a standard document that's been published. So that may be of interest for people to kind of see the process that's been articulated there, and that's what's sort of being followed at the moment by the subcommittee. So the subcommittee is rotating the time of their meetings a little bit, which I really appreciate from this side of the world, because I've been able to get along to some of that, which has been really excellent. They are starting to work back from what is clinically useful to know. So there's been a lot of discussion of where should we start in terms of, should it be a fixation standard? Should it be a sort of a checklist of what what tests to do in nystagmus? There was a lot of conversation about how useful is that clinically? What does that mean for management? How does that change things? How prescriptive is that going to be? What is that going to mean? And there was a lot of conversation around some of that. And so now that committee is really working on listing out what are the clinical questions that we want to be able to answer with some of these, because that kind of dictates then what is going to be needed for eye tracking. So depending on what the actual question itself is it waveform identification? Is it looking at the fixation elements of it? So kind of answering those questions. So at the moment, that's the document that they're putting together and working on, is what is the clinical questions. There has been some discussion, and I would love some thoughts around looking at some pieces of work on the circumstances in which eye tracking is useful for making decisions. Because there's been a bit of conversation at the full spectrum of people saying, well, anyone who's got nystagmus should have eye tracking done, versus the other end of the spectrum where people are sort of saying no one needs to have eye tracking done, what's the point? So looking at some of that cost benefit analysis. That ties in with some of the work that's coming through with the write-up of the survey. So the write-up of the survey is currently progressing along. We're working through, so the intro and the methods have been mostly, the methods well written. The intro, there is a draft sitting there at the moment, and we're working through the results section of writing that up at the moment. So that's where that subcommittee group is kind of up to. And so working on those different bits and pieces. Again, that is moving around in different time zones a little bit, which is really great.
Amanda, may I interrupt?
Yeah, of course.
I'm sorry, I got a little confused. The writing, introduction, methods, etc., that's for the guideline, or that's for something else?
For the survey write-up. So you know how there was a survey that went out around what is the current state of clinical use of eye tracking earlier on from ISCET? Yes, no?
I don't remember. I'm sorry.
No, that's okay. So there was a survey that went out that got developed that was basically looking, so what we want to characterize is who's using eye tracking, what sort of eye tracking. So answering those questions of what's currently happening in clinical eye tracking is sort of that broad question, because we don't know. Like, we don't know who's using them in what context. So there was a survey that went out, and that's currently being written up by a sort of a subcommittee group as well.
I understand. And the when you say written up, it's not an internal report. It's written up as a paper.
Yeah, that's the plan.
Got it. Okay, thank you.
That's right. So that's currently what's happening in that space for that one. So yeah, there's some conversation around circumstances in which eye tracking would be useful for making management decisions. There was conversation in the last meeting from Jay and some of the others about whether or not it would be useful to have a retrospective analysis, maybe some pulling of data of where eye tracking would have made a difference to management. So looking at, obviously not everyone who has wiggly eyes gets eye tracking at the moment, but trying to make that argument for integrating it, because one of ISCET's kind of aims is to bring more people into clinical eye tracking. But one of the pieces of work that I think probably needs to be done, and sort of some of the conversation at the moment, is around, well, why is that important and what's the cost benefit? Particularly with a lot of the eye trackers not having a CE or being able to use, not having a clinical marking on them at the moment. Often that's happening in places that do that combination of clinical and research and getting the eye tracking through the research side of things, where they've already got the eye tracker there and are sort of set up. So there is a little bit of conversation in that space of actually articulating the value of eye tracking and the point, or not, if that's how the pieces kind of come out. But yeah, so looking at that space, I don't know whether or not that will be something that needs to kind of be held over and thought about. But at the moment, we're kind of working on that first guideline. But yeah, that brought up also additional sort of conversations around what would be useful to extract from eye tracking, and I think that is going to come from that clinical question. So that's really where that piece kind of comes from, along with that need to include some flexibility. So particularly if you've got a young pediatric patient in front of you, you can't really necessarily have a prescriptive protocol for a 4-month-old, for example. It's always going to be juggled a little bit. Yeah, so there was some conversations on some of that. One of the questions that I have that sort of come out is, we're looking at putting together the membership grouping, and at the moment I think the plan is to put together a membership list, but to have it be a free membership at the moment. Because that will then allow us to have a voting groups to look at the organising committees and have a bit more structure around how some of that is kind of working. The thought from the last meeting was to do that after the publication of the first standard, or at least once we've got that list together. Has anybody got any thoughts in that space?
I had some thoughts, but before I get to that, tell me, so the chair and the co-chair are not on this meeting, correct?
Correct.
I see. And that's a bad start. Is one way of looking at it, but okay. The back to the survey and the clinical question, I guess I may have joined late. I don't know, or my memory may be failing me. I don't exactly know what the questions were. And but I'd like to, I guess, point out that my personal perspective in terms of congenital or early onset inherited retinal diseases and its relationship to eye movements would be an important question of this guideline, in my opinion, would be to evaluate changes in eye movements upon interventions.
Okay.
So this is a field of great interest to me, maybe to nobody else. But as you may know, there is increasing number of gene-based therapies being evaluated in increasingly younger kids in my space, in the inherited retinal disease space, and often, maybe always, they have oculomotor abnormalities, and often and almost always, one of the questions is the intervention helping with the eye movements? It has been a controversial subject going back to 2007, Now, 20 years later, it remains a controversial subject, at least in my field. And at least in my opinion, the guideline should include an aspect of this area. I'm not so sure how that fits into the quote unquote clinic. I do clinical vision testing, but I'm not a clinician myself. But that's something I don't know whether that was captured in the survey. If not, whether that can be included is an aspect that I like to suggest.
Okay. That can definitely be included and should be included, I think, at least in the clinical questions for the nystagmus guideline stuff. That is absolutely still a work in progress. I'm on that subcommittee, so I'm quite happy to add that to the list. But I'm also happy if you wanted to come along to some of that. I think it's a pretty open sort of piece. So there is the option to be on that subcommittee if you wanted to be. I'm just having a
Well,
look.
if it's going to lead to this guideline, or if it's going to predate or set up, I guess, for this guideline, sure, yeah.
Yeah.
I would love to join.
Yeah. I might put Helena's email in. There should be on the website the forum option to be included, and I think putting it up there would be useful. Hang on. Sorry, I'm not great at navigating the page. Because I think that's an important, like, a lot of the conversation has come from clinicians who are looking at generally infantile nystagmus, but looking at that diagnostic of what's going on with nystagmus. And I think to your point of looking at it, like you're looking at it from an inherited retinal diseases perspective, but even from a nystagmus question, like an INS question, you know, what happens before and after surgery, for example. I think that's important. So that whole question of what is going on there.
Yeah, and again, I don't know what's done clinically for just some random child that is walking into the clinic with nystagmus, but I would argue that it's somewhat of an easier question to answer. Did we make a difference? So that, at least in my mind, if I was dealing with it, you know, is A different than B is an easier question than what is A and what is B. Those are much more open-ended questions of, you know, defining the nystagmus, as opposed to is one is better than the other. And you know, the old rule, which is I'll know it when I see it, is certainly one way, but it would be great to define you know, parameters around that, and as I said, I feel like the guideline could help a lot.
I'm just having a look at what's on the list at the moment. Question, the special its characteristics. Okay. So at the moment, the questions that have been put in that document, and I think it's a really useful point, is does this patient have nystagmus? What type of nystagmus does the patient have? Does this patient benefit have a null zone, and what are its characteristics? I think that's a relevant. I'm just going to add it here so it doesn't get lost, but I think it would be useful to have that additional perspective. So is there a change in nystagmus from a management option? And I'll put a note here. Is that
And
the
of course,
best way to word it?
I know
Sorry.
nothing about I'm sorry, go ahead.
Is that the best way to word it? So I put, is there a change in nystagmus from a management option?
Well, yeah, after an intervention of some sort, right?
Yeah.
Um,
Management option.
and of course, I am solely focused on gene-based interventions, but presumably there is, surgical interventions that go back much further than that. I don't know if that's still done with the muscle surgeries, or is that an old thing?
Yeah, for sure.
So then it becomes a broader question that when you intervene of any sort, are you making a change?
Yep. Yeah. Are you, if you've had surgery, have you made it better or you made it worse? In particular
Yeah.
cases, did you miss CPAN, for example? Yeah. Um, maybe different genetic treatments. Cool. I've made sure that's in the document. But yeah, I think having that additional kind of perspective, because it has been an interesting conversation having things from people who see sort of one type of thing clinically all the time. Some people who are clinicians, some people who are not clinicians, some people who work in systems where they throw all the eye movements at them and then they look at all of the data afterwards, as opposed to asking, this is the particular question I've got, so I'll do this test and I'll do that test. And I'll do it along the way, and having the clinician kind of run the eye tracking to do some of that, as opposed to people who see different kinds of nystagmus. So it's been an interesting and kind of broad question of one, sort of where to start, but two, how to think about it and where to have those different pieces. So that's fabulous. I've added that question into that subcommittee document. I popped a note there. But yeah, if you do want to, if you've got time, and want to be more involved, there is the option to sign up on the forum, but you could also email Helena. I think her email's on there, but I can send that through. If not, where is Helena's email? Is it forum?
So, excuse my asking.
Yeah.
Yeah. So the survey is ongoing or
The subcommittee is ongoing.
ongoing? Oh, okay.
At the moment, I guess it's sort of more like a project group type of ongoing. Yeah.
Okay. Okay. I said so deliver the questionnaire to the clinical hospitals.
Sorry, what was that?
Yeah. Question survey questionnaires has been sent to the clinical hospitals or clinical doctors.
I'm not understanding the question.
Oh, okay. Yeah,
Question
because
about the survey.
yeah.
The survey has gone out. The survey went out about a year ago. So that went out to a range of people. That went out to a range of doctors, a range of people clinically. That went out to a range of clinical bodies. That went out to manufacturers as well.
Okay.
Thinking about different perspectives and sort of what's used and how it's used. So that is currently being written up at the moment. There is that question of bias. Did we miss groups when we went out to putting that out? And I think that will be a question kind of in the background. As with all research, it raises more questions as you work through it, and kind of going, well, what about this piece and what about that piece? So that is another group that is kind of working on getting that initial work out, and moving where that needs to go forward. And so that's kind of the question of, does it need to, it is one of those next pieces of work articulating the cost benefit of introducing eye tracking. One of the aims of ISCET is to, most of us, if we are in clinical eye tracking, have come through clinical eye tracking through a research path for a lot of us, through that one-to-one kind of mentorship of having to have someone train us over a number of years to kind of get into the field. And so the question is, does it have broader utility than that? rather than having just very specialized clinics that you have to be referred into to be able to have eye tracking, is there the capacity to have that more broadly clinically available? Is that useful? Is there a way to, similar to how ISCET has then got standardized protocols, can you have eye tracking that is the same if you had it in Australia as opposed to having it in the UK, for example, and having being able to transfer that care as well? So there's kind of a range of questions and pieces that are being thought of and talked about and throwing those discussions around, because it has come from things like the ANN conference, where you've had people who do eye tracking all the time for nystagmus, being met with conversations around, well, I manage just fine and I don't have an eye tracker and I don't think it's necessary. So some of those conversations are happening as well.
Okay.
Yeah.
So once we are discussing about some specific disease or some specific procedure. We think about details. So for example, some nistamo system is once focused, but is still focused on the specific equipment or clinical disease.
So I think nystagmus is going to be the first guideline, purely because there was coming out of the survey, there was such a big push for that needing to have a guideline, needing to have some standardization. But also within ISCET, I think there is also a lot of people where that is their passion as well. That's where a lot of this has kind of developed, particularly out of the UK. They have a bit of a nystagmus network in the UK at the moment. So looking at how a lot of that gets managed, and kind of working through some of those pieces. Yeah,
Okay, so currently
yeah.
developing phase, yeah.
Yeah, I think that eventually there will be that need for other things like saccade protocols, for example, and some of those exist in a research space, but looking at what that might mean in a clinical space for neurology, for example. There was a whole discussion about vestibular nystagmus, for example, and the fact that there are very strong guidelines that exist already for some of that, because that's been so well established for such a long time. But thinking about the eye tracking needs for head thrust testing, for example, is very different to what you're looking at in terms of a tracker if you're looking at waveforms. Just purely thinking about hardware. So having some of that differentiation has also come out in some of those meetings.
Okay, so these activities are led by two or three subgroups.
There's two at the moment. So there's a survey subgroup, and there's a first guideline nystagmus subgroup. There is sort of threads for that on the forum. So if you want to have a look at the forum, there are threads for that, if that makes sense, in terms of seeing who's been put in those positions and why, and being able to volunteer for them if you do want to be involved. Yeah.
Okay.
Their meetings are also recorded. If you're particularly interested to follow along.
So everyone will join any subgroups, or we stay alone without a subgroup. So
yeah, absolutely. I guess that's why I'm trying to make sure at the beginning of this meeting I'm sort of giving updates on where those are up to. I think that's a big push for ISCET at the moment, is to kind of make sure that everyone's able to understand where those are going and some of the conversations that are happening in that space. I think it's been really interesting and useful for me to kind of see some people that are very, very clinical and doing things in that space versus researcher conversations, versus also then talking to manufacturers and seeing the different perspectives of what those things mean and what we kind of need to know. Yeah.
Okay.
Yeah, I have some comment. When you say eye tracking, I understand, you correct me if I'm wrong, that you're talking about eye tracking by imaging the eye externally. Is that a correct assumption?
That has been the
And
option that has been used most of the time. It has, so eye tracking with AO and retinal imaging has also then been brought up and sort of touched upon, and it's thinking about how some of that could be, and I guess that's part of why this first one has been labelled a guideline, is that we're sort of looking at what's happening at the moment, looking at what the evidence base is for what's happening at the moment versus just what's being done. And kind of keeping that open, because it is, you know, AO imaging and eye tracking with AO imaging is a whole nother group of eye trackers that we need to be thinking about and thinking about where that gets applied. But the question is, where does that get applied?
well, let's be fair. So AO is you know, single cell, but at a very top level, are you looking at external images of the eye to estimate eye tracking, or are you looking at internal images of the eye to know where you are in the retina and doing eye tracking? So a subset of that would be AO, internal retinal imaging. But in general, you know, retinal imaging versus presumably you know, corneal reflex type of imaging versus lens imaging, I guess it's the some of the external images versus retinal imaging is what I was thinking about. And of course, there's the category of electrophysiological monitoring of eye tracking too, which I assume would be a third category. So my assumption is correct that let me go back 1 second. For the guideline, is there any room for including retinal input as opposed to external imaging input?
Absolutely. I guess the point of the guideline is to sort of set a minimum benchmark. So they're looking at to be able to answer this clinical question, what is the minimum that would be needed in our tracking sort of space? And thinking about the hardware as a minimum sort of hardware. So we're talking frame rate, we're talking about precision, we're talking about some of those elements. I don't think it precludes things like retinal tracking, and that's where some of those questions have come up in other meetings and other conversations, kind of going, well, you know, this is a whole other category of hardware effectively with different pieces to it. And so that's where I think we're trying to be hardware agnostic, in that we don't want it to be one particular brand, one particular bias towards, you know, this clinic uses this particular piece of tracking. So they're wanting to sort of set a minimum specs, I guess, rather than anything else, to kind of go, these are the things that need to be answered this is what you need to answer this clinical question, is kind of where the committee is going with that, because they're wanting to be as agnostic with that as possible. So I guess where that would come down to retinal imaging would be if you sort of said, look, the precision needs to be at this, you know, couple of cells type level, then these are the sorts of trackers and the sorts of systems that would need to be discussed. So I think it is going to be going down that path of what is the clinical question and how do I use eye tracking to answer that, what is needed, what sorts of protocols are needed, what sorts of data analysis are needed, and kind of putting those in place. So that's kind of been the conversation so far. Does that make sense?
Yeah, it does. You know, again, from my perspective of inherited retinal diseases, I'm always fascinated when people talk about fixation, and but there is no data to support with external imaging as to what is being fixated on, and what part of the retina is being used to fixate it on, which, at least in my world, is very, very important. So So I feel a conflict or an internal struggle as whenever possible, we look at retinal images and movement of retinal images. And of course, in some cases, that's not possible because of the size of the movements. But for nystagmus in quotation marks, where one is maybe referring to fine nystagmus, then often looking at the retina is certainly an option. And so I just was wondering whether that will be amalgamated into the guideline or whether that's a whole another direction that one has to consider separately.
I think it will be, but I also think it's a useful piece to have that constant reminder and that constant other voice of a perspective that isn't seeing INS with a remote view tracker, because I do think there's a lot of that coming through in terms of thinking about where these things are applied. So I think in these committees, it's very useful to have, yes, people who are doing it clinically all the time and are thinking about the clinical questions that are attached to that, but then also thinking about the other diverse perspectives of where this might be applied. So that's where I'm happy to pass some of these on and pop notes in, but if you do want to be involved, that would also be very encouraged and welcome, if you've got that kind of time. Sorry, I realise that is a big commitment to join some of these things as well, in busy academic lives.
Yeah, yes, but it's okay. It's good. It's for a good purpose.
Yeah. Yeah. Were there any thoughts? So that kind of covers the nystagmus subcommittee update and the survey write up. Yep. Sorry, did I miss a hand? No, that's okay. Yeah, but yeah.
I know I may have interrupted you or added when you asked a question, and now I can't remember what your last question was. Can you remind me, if you don't mind?
That's okay. I think we're also then getting up to talking about organising membership that has no fees attached to it, but what should be in the membership categories. Is everyone happy with that as a sort of a plan moving forward? Can I get a thumbs up? That was what we did in the last meeting, either with the emojis or with a thumb on screen. Don't mind.
Yeah, it's good.
Cool.
Okay.
Nakayama, up, down.
Yeah, it's okay.
That's okay. Cool.
Okay.
Yeah.
Yeah,
So
up to you.
thank you. Sorry. That will allow us to organise voting in terms of organisational committee, but also kind of giving things a bit more structure. Currently, we work on regional meetings, and we have, as you guys are aware, we have those rotate through the different time zones, and that allows us to kind of make sure that people are in all those time zones are given an opportunity to have input and different perspectives. And there's definitely been some conflict and different pieces that need to be adjusted between the different meetings. But I think that's kind of useful, as you've just demonstrated, for things that need to come up and come across. Yeah. One of the pieces that has also come up when we're thinking about the guideline is to think about whether or not we house normative data and whether or not we house open data format for eye tracking as well for some of those kind of minimum sort of guideline pieces. So if we're saying, hey, this needs to have, say, 20 saccades, for example, housing some of the open format coding to do some of that. And then thinking about the protocols themselves. So at the moment, what we're sort of seeing across the board is this, this person trained me, therefore we go out in 5-degree steps to the right, and then we always go to the left and we start that way, and we don't necessarily calibrate. And so we're seeing some of that come through in clinical testing, and then having a different piece when we see people who do it for research who have a very set protocol of this is exactly what we do, and how that's a little bit different. So there will be some sort of discussion in that space as well if there are pieces that anyone wants to add to. And then also thinking around the processing of data. So thinking about how that data gets analysed and what pieces need to come out of some of that testing.
Well, I would argue data analysis, starting from the last, is well beyond my concept of what the guideline should include. That seems too much to me. And in terms of places to house data, I would argue if the guideline will be published by a publisher, that would be the place to put it, as opposed to much more internal or less reliably to be around long-term locations of data. I mean, I would guess or that associating it with the paper somehow would be one way of going about it, and then or using some of these data hubs that have been around for a long time, I guess is the other way. But I guess what you're thinking is like sample data so that people can compare theirs to the standard or usual or typical or something, and be able to say or say something, I guess.
Yeah, the conversation has sort of been around how do we make this easy for a new clinician in this space. So that is why the analysis question and including suggested analysis in a similar way to how we think about say a visual field, and we're sort of told how to read a visual field, or we're taught how to read a visual field and the things to think about. That doesn't necessarily mean that, you know, someone can't do something a little bit different in terms of how they're interpreting that data, but having that as sort of a minimum way to do things, to introduce it and make things easier to introduce new clinicians has been the thought process. Along with exactly that thing of, well, is this normal? What am I looking at? Is that, you know, not normal? Having that normative data. I don't know that we have that normative data yet, so associating it with the paper in something like supplementary material, I think would be difficult. It probably will need to be in a data hub, but it is a conversation at the moment of where does that get housed and how, and kind of where are we putting that and why, and how do we contribute to that appropriately, which are all kind of open questions. We are still in that phase of working through how do we get a membership list together and get that organised. So it is a bit further down the track for that, but wanting to flag that just in this space and in this meeting so that we're kind of starting to think about some of those questions. We are following the ISEV model at the moment, and we've been very lucky to have a couple of the ISEV members join the subcommittee for the nystagmus one. I think we've got...
Me too.
Yeah.
I'm an ISEV member.
Yeah. Well, welcome in the nystagmus subcommittee. I think that would be wonderful. But yeah, kind of having that process and that being the way that we want to do things. For lack of having another model, I guess. Because I think they voted and were happy to contribute, so it's kind of being that joint sort of partnership type work on that. That's everything I have on my list at the moment. Did anyone else have any other business or anything else they wanted to add to this meeting?
Yeah, so one point.
Yeah, of course.
So I said we'll organize a workshop and so next ETRA. Yeah, it's a very simple questions. Yeah, because so I am a workshop chair to organize a workshop at the ETRA conference.
Yep.
So then if more detailed discussions about clinical aspect of eye tracking, it's a good chance. So then
do you have a meeting that you think that should be attached to?
Yeah. So I will send some information to who is key person.
It can be anyone in the organizing committee. There's myself for our area, there's Robert, there's Russia, Matt.
Russia, okay. Russia,
Probably
okay. I will
Yeah.
send the piece of information is Russia. Okay.
Yeah, or to me, or to Matt, or to so any one of us, I think, could probably bring that forward. But actually, probably post it in the forum. I think more than anything.
Okay.
Yeah.
Okay, I'll check later.
That's all right.
Okay,
I'm happy to put that one out more broadly to the ISET group, and they can raise that in the other meetings as well as to where. Because I think that would be wonderful if we had an ISET sort of
Okay.
satellite meeting, I guess, attached to one of the big conferences that people are likely to be at, whether that's, you know, visual neuroscience, ARVO, one of the other nystagmus meetings, something. But I think it would be working out where that kind of gets situated and what kind of makes the most sense.
Okay.
Yeah.
Anyway, so I try. Okay, thank you.
But yeah, please send those details through. If you've got a meeting that you think would suit having a satellite meeting of ISCET, that would be wonderful, because that would be helpful to come from the membership.
Yeah. Yeah, anyway, I will send you a short message by email.
Okay,
Yeah.
perfect. Thank you.
Okay.
Anything else?
I don't have anything. Thank you for leading this discussion.
Yeah, thank you very much.
Thank you both for contributing and being here. It is wonderful to chat with people and to have input. I really appreciate it.
Yeah, and please say hello to Lauren and yeah, since Nakayama, what do you do? What do you do?
Yeah, so I originally working in pupil response. So I currently have an interest to clinical application of eye tracking and pupil responses. So then I join here.
Nice. I think ISEF is trying to organize a separate pupillary consortium or group of people that try to generate a pupillary guideline also. So I don't know how that's coming along, but I'm very interested in pupils also.
Yeah. So my personally hope is ISET will present a piece of example data, eye tracking or something. So all members can freely analyze these data. The several type of analyzing methodology or how to say assessment procedure will be developed by several members or subgroups. Yeah, it will be good research activities in the future.
Yeah.
So hope to gather not a large small size is maybe possible. Several clinical samples, nystagmus, any type of data will shared with a member of the ISET. It will be key to the next our activity, I think.
Yeah.
Great.
Yeah.
Sounds good. I will draw this meeting to a close if we don't have anything else. Thank you for being here and for wonderful discussion.
So thank you very much.
Thanks.
Bye-bye. Thank you.
Bye. Thank you. Bye.